Emerge a humbled individual. Why things work and why they don't and how we can improve things. So this is an important audience for me because we definitely need your help. I'd like to talk to you about diagnostic error and whether we can improve that with decision support and with artificial intelligence more specifically. I've been worried about diagnostic error for 20-some years now, and if I can briefly summarize what we've accomplished in those 20 years, we know a lot about how frequent these errors are. They are very frequent. We've learned a lot about where they happen, in the ER, in primary care, in the hospital. We understand why they happen, thanks to our human factors colleagues. We appreciate the system-related factors. We appreciate the cognitive things. We've learned all about heuristics and biases. So we know all these things. And over the past 5 years, people have started to propose solutions. Okay, the problem is heuristics and biases. Well, we can stop and think. Well, we can make the patient our partner. We can get a second opinion. And these are all great ideas. But after 20 years, I can tell you with a fair degree of confidence, we have not made one iota of progress in terms of reducing the likelihood of diagnostic error in practice. There's no evidence at all that anything has improved. So here I am, a star is born with artificial intelligence, and I'm kind of hoping this is the answer. So that's what I'd like to talk to you about. You've heard some skepticism and whatnot from our colleagues in the human factors world, but I think a lot of people would say that artificial intelligence has been transformative for the visual fields of diagnosis. So I can take a picture of a lesion on my skin, and there's a program that will tell me exactly what that is. There are programs that can look at your prostate biopsy and tell you whether or not you have prostatitis or cancer. And there's programs that can help you with your mammogram that can tell you with exceptional degrees of reliability whether or not you have cancer. So I would say, and I may be going out on a limb here, that AI has been a real success in the fields of visual diagnosis. And I'm happy for you. I'm happy for all the radiologists who are using this successfully, and I'm happy for my field, because this is an area where I think diagnosis really has improved. But I'm not a radiologist, I'm an internist. And my question is, can artificial intelligence help me and my colleagues in the clinic and in the emergency room and in the intensive care unit? One thing that is real progress is that the likelihood of error and the importance of it is now, I think, appreciated. In 2018, ECRI said that diagnostic error was the #1 concern in patient safety, the #1. And this is going from like the bottom of the list to the top, because when To Err is Human was published in 1999, diagnostic error was barely even mentioned in that report. Patient safety in 1999 was all about preventing falls and medication errors and wrong site surgery. And those are all very serious problems that are worthy of addressing. But diagnostic error was not on the list. So it went from the bottom of the list to the top in 2018, and ECRI has repeated its #1 designation several times since 2018. So this is a big problem. It's recognized to be a big problem. A report came out in 2015, again from the Institute of Medicine, on improving diagnosis in healthcare that again emphasized what a critically big, important problem this is to address. The World Health Organization now recognizes this to be a problem. Last year, the World Health Organization's Patient Safety Awareness Day was dedicated to diagnostic error. So it's not just in the United States, it's internationally recognized as something we need to do something about. And this is not just a theoretical and academic discussion. It's something that could affect each of us. There's a quote from that 2015 report. Each of us is likely to have a diagnostic error in our lifetime. And some of these are going to have devastating consequences. So it's a real problem for me as a doctor, and it's a concern for me as a patient. Just curious, how many people in the room have you or has a member of your immediate family experienced a diagnostic error? Yeah, thanks. It's easily half of the room. Why are there so many diagnostic errors? 4 years of medical school aren't enough? Well, the problem is diagnosis is really hard. There is variability and there's complexity that affects every step and every part of this process. It involves me as a doctor. Where did I go to medical school? How much attention did I pay in class? What textbooks did I use? What patients have I seen since then to build my experience? All sorts of variability from one doctor to the next. There's complexity in our healthcare systems. One healthcare system is very different from the next one. How they're organized, how they're staffed, all these things add to the variability. And variability is the enemy of reliability. And with all the variability that we have in healthcare and in the world of diagnosis, it's perhaps no surprise there are so many diagnostic errors. This is a quote that I like. There are two kinds of diagnoses you will never make, the ones you don't know about and the ones you don't think about. So there's all sorts of reasons that diagnostics occur, but this is a lot of them. I'm seeing a patient, they tell me their symptoms. Within 11 seconds, I think I know the diagnosis, and that's how doctors operate. A lot of it is by recognizing very quickly, system one, what's going on? And then we're very confident. We're in fact overconfident in our diagnoses, but that's a story. If I don't consider all the other possibilities, I'm going to miss something. And doctors do not consider all the other possibilities reliably. There are studies that looked how often there's a differential diagnosis in your chart when you go to see the doctor. Anybody want to venture a guess? 20% of the time? It should be 100% of the time. In ideal circumstances, the doctor would always be thinking about the other possibilities. Doesn't happen. We focus in system one. Okay, so can decision support help us? And the story of decision support to help diagnosis goes back a long ways. And there are some very simple kinds of decision support that we've had available to us for quite a while. So this is a colleague of ours, John Ely. He made a little notebook. It's about 60 pages long, and each page is a given symptom. And for that symptom, what are the possible diagnoses that you should think about? So if I'm seeing a patient with back pain, I can open up John Ely's little checkbook, or I have a copy of it on my phone, and I can look at what the differential diagnosis of back pain really is. And 90% of the time, it's something related to degenerative joint disease, something with their spine, but there are some serious things on there that need to be considered. Is it a dissecting aneurysm? Could they have metastatic cancer in their spine? And this is the severity aspect of diagnostic error. What seems like a trivial failure, the trivial error of not making a differential diagnosis, can lead to your missing the diagnosis of a dissecting aneurysm. So this is a simple decision support system. There's others that are even simpler. I don't even have to carry it around. I don't have to look on my phone. I have it memorized. I know what vitamin CC is. I know what Vindicate is. It helps me go through the differential diagnosis of a problem. Google came out around 2005. I don't know, I may be a little bit off there, but I was already working in this field of diagnostic error, and I was thinking Google's going to solve all our problem. But here's a study that was done using Google. The sensitivity in terms of it being able to come up with the appropriate differential diagnosis was horrible. the sensitivity was under 60%, and the specificity was even worse. So in 2006, Google was useless for helping improve diagnosis. But, and there's a big but, if you fast forward a bunch of years, Google's come a long way. Here's a study that came out in 2023 showing that Google is now the cat's meow and does an exceptionally great job with diagnosis and differential diagnosis. So there's been a tremendous amount of progress in these tools. We've had other decision support products available for a long time as well. And these are not like Google, which is like all of knowledge. These are focused on diagnosis. And they're not all actually artificial intelligence based. DXplain, which is the oldest one there, is a rule-based system. It's Bayesian logic. It's based on the probability of disease and how much that probability changes based on whether you have this particular aspect or you don't. And these things work, as you can see over on the left. You put in the patient's symptoms, 2 or 3 things, and within 10, 20 milliseconds or so, you get a differential diagnosis. So this is great for diagnosis. It's great for differential diagnosis, but there's a problem here that I hope you can appreciate. It doesn't tell you the diagnosis. It gives you a list, and there's the hope that the real diagnosis is on that list. But you don't know if it's the first thing on the list or the 9th thing on the list or a diagnosis on the next page that you would have to scroll to before you even saw it. So these are terrific, but even these systems have some built-in limitations. This was a study that was done of Isabel when it first came out. It's not a great study. It wasn't published in a great journal, but it caught my attention. It was done in a pediatric ICU, and the residents either diagnosed cases on their own or they used this tool, Isabel. And on their own, they got the diagnosis right 89% of the time. With Isabel, 92% of the time. Not a very big difference, is it? But to me, it was an incredible difference. This is exactly where we are in medicine today. We're at 90%. We get it right 90% of the time. How are we going to get to 92% or 93% with these kinds of tools? So instead of 10 kids, 10 children, babies, at risk for diagnostic error and serious harm, it's down to 7 or 8. And that is, in my book, real progress. I was very happy to see this study. And since then, all the large language models have come on the scene, and they are just like unbelievable. This is The Star is Born. The performance is breathtaking. This is a graph that shows how they perform on the USMLE, the licensing exam to become a physician in the United States. And you can see that, from not too great several years ago, just over a very short period of time, 2 or 3 years, it's way up at the top. And if you extrapolate this curve out to like next year, they'll be at 120% correct answers on the USMLE. It's unbelievable. I'm a little bit skeptical of studies like this, though, for one reason. Do they do so well on these exams because they're so smart? Or is it because they have soaked up in their knowledge base all the questions from last year or the year before? And they don't ever really get into that when they publish these kinds of papers. So I'm a little distrustful of studies that use these testing exams as the baseline, as the benchmark. I'd much rather see a real-world study. And here it is. This is a real-world study, if I could say it correctly, that came out 2 months ago. This was conducted by a colleague of ours in Switzerland, Wolf Hautz. It was done in 4 academic medical centers in their intensive care units, and they focused on the most challenging patients. So these are not the people who have maybe a broken finger and the finger's pointed this way. These are people with nonspecific symptoms or abdominal pain, fever of unknown origin. And in this cohort of high-risk patients, did decision support improve the outcomes? And the result was what you see here. The risk of diagnostic disappointment, failure, was identical in the patients who were diagnosed just by the physician as in the group of physicians who took advantage of one of these large language models. So how do we interpret this result? I'm glad that it was done in a real-world setting. I think that's where they all need to be done. I'm a little disappointed that it didn't improve the diagnostic performance. But on the other hand, you can look at it and say, the decision support systems function just at the same level as these physicians. And I think I said that it was done in an academic medical center, a teaching hospital. This is not the place to be studying these systems. In an academic medical center, the residents are interviewing the patients, they review the case with the physician, there's a built-in second opinion, your colleagues may weigh in. So maybe if this study had been done, I don't know, in Africa or out in the middle of South America somewhere, the results would have been dramatically different. So here we are at a state and time where we have these large language models. They're available to us. They certainly work in radiology, and I'm pretty sure, if I could predict the future, that they could help us in medicine too. One problem right now is that they are all operating in the pull fashion. And this may explain why they're underutilized. These have been available for a long time. Isabel's been out for 15 years, to explain for over 20, and physicians have not been using these. And why? Well, one reason is that it takes effort. You have to stop and enter the data and in a pull fashion, get it back. Maybe these would be adopted more universally if it was done in a push fashion. So instead of you having to stop and ask for the answer, it gave the suggestions to you without you having to go through the steps. But there's a problem with this too, and it goes back to some very old studies. This was a study done in Kaiser Permanente. They had decision support available to help the doctors. I think it was to choose which is the right test to order. And it was underutilized. It wasn't used hardly at all. So Dean Sittig did a study. He asked them, why are you not using decision support? Don't you know that it helps you take better care of your patients? Oh yeah, I know that. You know, won't it help you improve outcomes? Yeah, we know that it'll do that, but it was underutilized, and it's because I'm behind schedule. I don't have time to use it. A second study done in Vanderbilt. Does anybody know Paul Mongerson? Well, Paul Mongerson is the reason I'm here, and he's probably the reason that some of you are here too. Paul was an engineer and ended up being the president of Stanodyne Corporation. He developed abdominal pain and was told, Paul, you have pancreatic cancer and you have 6 months to live. At the end of 6 months, he was just fine. And he ended up living a long life, but as an engineer, he was puzzled by how he could be told that he had this fatal diagnosis that he didn't have. How could this be? One of the things Paul did was to donate some money to Vanderbilt so they could build a deluxe EMR. It was one of the first in the country, and beyond building the EMR, to build in some decision support functionality. So for those of you who work in the decision support business, I think you owe a little bit of debt to Paul Mongerson. Another thing he did was to convene a meeting at his home in Florida. I was there with Ida Berner and Gordy Schiff and Pat Crosscarry. There were 6 of us. And Paul was asking us, you know, what can you do about diagnostic error? And we didn't really have any good answers for him. But that meeting was the nidus, the start of the Diagnostic Error Conference Series, which is continuing today. And it was the foundation for our nonprofit Society to Improve Diagnosis in Medicine. So huge shout out to me posthumously to Paul Mongerson. Okay, so here's a study that they did at Vanderbilt. They had this wonderful decision support available. It was underutilized, less than 1 or 2% of the time. So is artificial intelligence the answer for diagnostic error? I don't know. I think it could do the job if doctors used it. but they're not using it. And I'm puzzled by that. I don't know why. I'm a lot more optimistic that artificial intelligence will save the day in another fashion. And it's because of these things. In the last 2 months, there have been publications on each one of these topics, ways in which artificial intelligence can be used to save the doctor time, helping with billing codes, helping with responding to patient messages, all the little chores that chew up your hours in the day. So if artificial intelligence excels in these things, I think there could be very rapid adoption. And maybe that will help us improve diagnosis, because then you have more time to think, more time to get a second opinion, more time to consult decision support resources. So I am optimistic, not by artificial intelligence working directly, but via all the ways it can help us save time in delivering healthcare today. So this, I think, is the answer. Artificial intelligence will be extremely helpful as a physician assistant, whether or not the doctors choose to use it or not in their practice. So the jury's still out. I would love to come back in 5 or 10 years and give you an update on where we're at, because I don't know where we will be in that period of time. But I would like to leave you with a puzzle, and that is, why is it in radiology that artificial intelligence is used universally, even though the diagnostic error rate is only 1 or 2%? But in medicine, where the diagnostic error rate is 10%, it's used almost never. So if anybody knows the answer to that, you please come find me and tell me. Thank you all very much.